It's a really pleasure for me to introduce Dr. Piedra with us today. Dr. Piedra, he's a professor of pediatrics, actually, at Baylor College of Medicine. He's a pediatrician, a trained infectious disease in pediatric population, and now he's the head for many years of the virology diagnostic lab, and he is doing lots of work on influenza, RSV, and other respiratory viruses for many years, especially in vaccine also as well. And also he really shaped the field of vaccine, especially for RSV and influenza for the past many years. He's also on the FDA committee for to study the vaccine effect. And he's going to talk to us tonight on the neutralizing antibody actually for RSV in pediatric patient as well in stem cell transplant patient. And thank you for coming.
Good evening. It's my pleasure to be here. How many of y'all were in the earlier talk? Heard my talk already? Well, that's excellent because I already see it's that table that I need to ask questions. This is a little bit different because it's antibodies, right? So it's less clinical. And so what I would like to do is to at least try to tell you a story. And the story will first evolve as to what is, let's say, is there a magic titer? Is there a particular threshold neutralizing antibody titer that is relevant with reduction of RSV-related hospitalization? And I'll show you data that we've developed, and the answer is yes, there is. Then I would like to show you clinical data, some that has been generated from MD Anderson and some that has been generated from South America with different diseases as to the relevance of neutralizing antibodies. And then I would like to really show you data so that you all can understand the power of antibodies as to what it means when I tell you a certain titer, and so that you can appreciate that if I tell you 6 to the log 2, to you it means nothing, and I understand that. But at least to get a feeling that there is major difference from a 6 to 8 to the log 2, and I'll show you what I mean by that, because it has a tremendous impact on the benefit of an individual. And lastly, I would like to put out a hypothesis, and that is what I will show you for RSV may hold true for other paramyxo viruses. And there's an event that we have observed from a small pilot study that Roy and I and Dimpy and others are doing, and that's to show you why some adults are so vulnerable to RSV infection. And I'll try to evolve that hypothesis at the end. With that, there's been I live in the vaccine world, and so it becomes very relevant to try to understand when you're developing a vaccine, what relates to protection, what level do you need to achieve to get there. And likewise, I live in the world of maternal immunization, so it becomes very relevant if you give a vaccine to the mother, you want to see the benefit transferred to the infant through the placenta, and you would like to be able to predict half-lives and so forth. So one of the first things that we wanted to try to establish was, is there a protective level, a minimal protective level that you need to reduce the likelihood of hospitalization? And we did this study from a cohort of individuals that were enrolled over a 5-year period. And we studied a cohort of individuals who had acute and convalescent blood samples, and we had obtained their nasopharyngeal aspirate for virus isolation. And all of these individuals were hospitalized for a respiratory disease, for acute respiratory disease. So they could be hospitalized for RSV, parainfluenza, influenza, something else. But they were hospitalized for an acute respiratory disease event. And what we observed was that for those who were hospitalized due to RSV, that there was a particular antibody level that seemed to make them vulnerable as compared to those who were hospitalized for some other cause other than RSV. And the threshold titer that we observed was you were protected against RSV-related hospitalization if you had a titer of 6 to the log 2. Now, this table over here, what's 6 to the log 2? Arithmetic number, real quick. 1 to 64. So that's low levels. That's not high levels. But look at the efficacy. The efficacy of that was about 70% reduction. That's better than an influenza vaccine. The effectiveness or efficacy is about 50 to 60%. So having that antibody on board really prevented, at least in this cohort, RSV-related hospitalization. So what we wanted to do was to develop more data. I told you the study. The other thing that we observed was the more is better. So having the threshold titer is good, but having more is better because for every log increase in neutralizing antibodies, we were able to observe a 20% reduction in the likelihood of hospitalization. And this story is going to occur not only with our data, but with many other people who have published in this area, that they see this correlation that every log increase, there's a reduction in the likelihood of hospitalization. This is to show you the threshold titer. And this is, not all assays are created equal. And this is the assay that we use. It's a microneutralization assay. In the years, we've been doing this assay now for over 25 years, and we now have what we would call qualified it. And a qualified assay is basically used for licensure of vaccines. So if somebody is interested in licensing an RSV vaccine, this assay will allow you to assess the immune response, the neutralizing antibody immune response, and generally the FDA would be fine with that. They'll audit it, they'll inspect it. But that's what a qualified assay does. It's a very stringent assay to ensure reproducibility over time. Well, one of the things that we wanted to do was to validate this threshold titer. And we did that by looking now at all the individuals that were enrolled in that original study, which was close to 600 subjects. And we had acute blood samples on them, and we made the criteria for RSV infection more stringent. Rather than just relying on serology and or culture positivity, we relied it on culture positivity. So we made it more stringent. And we asked the same questions. Do we see a particular level where there's going to be a difference in the likelihood of RSV-related hospitalization versus not? And the answer was yes. We divided the data into quartiles, and for those individuals who had a neutralizing antibody titer of less than 6 to the log 2, you can see that most of the RSV-related hospitalization occur in that group compared to the other quartiles that had higher levels of neutralizing antibodies. And in fact, if we look at the threshold titer of 6 or greater to the log 2, we see the same degree of efficacy or effectiveness in this validated cohort. And thereby, we're validating our model, we're validating the original observation that this titer appears to be a good correlate for predicting protection against severe disease. This does not mean that they're being protected against infection. That's different. But they're being protected against severe disease. And again, in this cohort, we observed the same, that for every log increase in neutralizing antibody, we had a certain decrease in the likelihood of hospitalization, and here was close to 25%. I want you to remember this graph. This is really looking at seroprevalence over age. It goes from basically from birth through older adults. And I don't give you the numbers, but this is, remember, 600 subjects, and each group has at least anywhere from 20 to 100 individuals. And the first three are in months, so 0 to 0.19, 2 to 0.39 to 0.39 and 0.4 to 0.99, that's months or a year, a decimal of a year. My point is that group, those first 3 time points, are in infants under a year. And you see what you should expect. Most of these children, most of these infants have antibodies from their mothers. That's neutralizing antibody, and so you expect a particular decay, maternal antibody decay. And what you also see is that in the next subsequent years, 5 to 10 years, it really takes a number of repeated infections before you start to generate an antibody response that is comparable to an adult level. And once you have achieved that, it seems to remain, at least in a mean group, that level seems to remain there. This shows you something slightly different, and that just says, simply based on the neutralizing antibodies that you have at any particular time in, let's say, the age of the population we're studying, what is their serosusceptibility to getting a severe RSV infection? It's not looking at comorbid state, it's not looking at the amount of virus you're getting, the type of virus, your innate immune response. It's simply saying, looking at the antibodies that you have on board, are you more likely or less likely to develop a severe RSV infection? And as one would expect, children under 5 years of age are more likely to develop a severe RSV disease compared to older. And this was either with the validated data set or with the model. But note that there's a sizable proportion of adults that have what appears to be low levels of neutralizing antibodies at the time that these samples were collected. And I'm going to show you that data again, but in a different population, and this will be the MD Anderson population. One of the things that, as a pediatrician, it's a no-brainer. RSV is the major respiratory viral disease of infants and young children. It causes, I would say, the major cause of bronchiolitis and pneumonia, and major cause of hospitalization, and now is probably one of the #1 causes of death worldwide due to respiratory disease in children under 5 years of age. The data in adults is more sparse, and most of the data has been generated by colleagues in Rochester, New York, Ann Falsey and Ed Walsh, and some by other folks, that says that about 10 to 15% of adults older adults, in particular those with underlying lung disease, may end up hospitalized from RSV disease during the RSV season and flu season, during the winter season. And so if one translates their numbers and also look at the impact or mortality, it is estimated on an annual basis that about 15,000 adults in the US die from RSV. Now I'll ask y'all are in a special population, but if you were to ask internists, infectious disease people in non-immunocompromised population, RSV may not be on top of their list. This was a study that was done in countries primarily in South America, Brazil and in Chile and in others, that asked the question, what is the major causes of community-acquired pneumonia? They looked at bacterial and viral causes, and RSV was one of them. And we perform all the serologic assays for RSV and also for human metapneumovirus. And what we observed was this population, 95% of them ended up in the hospital from their community-acquired pneumonia. And many of them were healthy adults. But note that there was about 13 to 14% of the individuals that were hospitalized from community-acquired pneumonia attributed to RSV. And likewise, if you look at, I don't have a pointer, but if you look, those who were infected with RSV versus those who were not, those who were infected had lower neutralizing antibody to the virus compared to those who did not have an RSV-related community-acquired pneumonia. But the difference was not big. It was just one log. And if they used the threshold that we had defined primarily for children, they noted that 17% of those adults who had RSV-related community-acquired pneumonia had neutralizing antibodies that made them serosusceptible, compared to 2% of those who had community-acquired pneumonia from some other cause. Now that to me, I did not expect that many adults to have relatively low levels, levels that we would see in children. And again here, for every log increase, there is about a 20% reduction in the likelihood of having community-acquired pneumonia-related hospitalization. So this number we continue to see in different populations. So the more, the better. This is kind of a composite. And what I want to show you is just to kind of give you an idea of numbers. And I'm not yet showing you what these numbers truly mean. But there doesn't seem to be much difference between a 6 and an 8, right? This is log 2. Normally we would say, well, 6 to 8, that's not much difference. But in logs, that's a 4-fold difference. Keep in mind that every log increase is 2-fold increase in antibody titers. And so the first thing I want to show you is if you look at the hematopoietic stem cell transplant patients, all of them were infected with RSV. At the time that they became infected, look at their levels of neutralizing antibodies. It's the levels that we're seeing in infants and young children, 6 to the log 2 or less, compared to other adults, whether they are from a healthy population. The RSV-F, this is a vaccine that's being tested in healthy adults, and it just shows you their baseline titer and their immune response following vaccination. You can see the adults in the community-acquired pneumonia study by Lushinger and others, those who develop RSV versus those who did not, their acute versus convalescent levels. And you can see the hematopoietic stem cell transplant individuals, the acute and convalescent. My point is they were susceptible, serosusceptible to RSV. So a question that one can ask is the RSV selecting, and you could say the same thing for other paramyxoviruses viruses, are these viruses selecting individuals in the general population of hematopoietic stem cell transplant who just have low antibodies because genetically they were likely to have low antibodies? An alternative story or alternative hypothesis, and we don't have the data, but we hope to develop the data in the next year to two, is that all the preemptive therapy, all the conditioning that they receive may, in a way, impair their T cell, B cell response, and thereby it's kind of like maternal antibodies to the infant. You're no longer making antibodies, and you're now going to have a decay, and there will come a time with that decay that makes them more susceptible to infection. And so that's going to be something that we're interested in trying to answer with Roy, Dimpy, and others. Well, now look at, this is the data that we published in Journal of Infectious Disease. And all means all, there are more individuals that have now been studied, but these were the first 2 years of the study. And look at their levels, whether it's to RSV-A or RSV-B. I forgot to mention, there are two major RSV groups, RSV-A, RSV-B. In each of the RSV groups, there are genotypes. So you all may think of RSV as being homogeneous, just one virus. That's not true. It is made of many different genotypes, and they have different sensitivities, and may have different pathogenicities. RSV-A-ON1, that's Ontario. That is a totally new genotype that we were the first to describe in the United States. And where did we first see it? In MD Anderson, in the population. This is a unique virus that has about a 72 nucleotide duplication on one of its surface proteins. That's kind of like French. The main thing is it's a new virus. It did not make it any more virulent to the individual. But there is data to suggest that this virus is circulating worldwide and that it may replace all other viruses because it may have a survival advantage. And this we have observed with the RSV BA, that's for Buenos Aires. That virus first originated back in around 1998 when there were many different genotypes of RSV-B. It has now become the dominant genotype that is circulating because it also has a 60 nucleotide duplication in the G gene that for some reason makes it more fit. Not more pathogenic, but more fit to evade the immune system. Now, diverting a little, look at the levels of neutralizing antibodies to these different variants by the individual. So those who have Ontario, they were infected with Ontario. Those who have the NA, they were infected with the NA genotype or the BA. And they have low levels overall to the RSV test antigen. What is also interesting is if the individual was able to mount a significant antibody response, they were able to clear the viral infection much more effectively compared to those who were not able to mount an antibody response. And so if you look at the table for those who shed virus for under 2 weeks, most of them had a 4-fold or greater response in their neutralizing antibody titer. It's not that the neutralizing antibody is clearing the virus. What we believe is that it signifies as a reflection of a reconstituted immune system that now is able to clear the virus effectively, compared to those who were not able to mount a significant immune response. This is animal data. So now comes my fun. But the major point that this slide is meant to say, and this is the data that was used to generate the concentration of palivizumab that was administered to infants. What they wanted to see was at least a 100-fold reduction in pulmonary virus titer. And it was that dose in children, well, that dose in cotton rats, it's what was translated to children. So based on the cotton rat data, they extrapolated that you needed about 15 milligrams per kilogram of palivizumab to achieve a particular level. And that trough level was around 30 to 80 micrograms per ml. I'll show you later what that means. The other part that I want to show here is if you want to have a 100-fold reduction in the nose, you need 10 times the neutralizing antibody activity in the serum compared to what is needed to reduce 100-fold in the lungs. In other words, it is considerably harder to prevent infection than to prevent severe disease. We're not treating it with antibodies, we're preventing. And that's how vaccines work. So this is more data from the cotton rat, but it kind of shines on the issue of what these titers actually mean. Here we administered different doses of palivizumab to the cotton rat and looked at virus reduction in the lungs. And about at a level of 5 to 6 milligrams per kilogram, we were able to reduce over 100 folds. Remember, now you start to get protected against severe disease in humans, at least 100-fold virus reduction in the lungs of these cotton rats. Well, look at what 5 milligrams per kilo, 5.7 milligram per kilogram translates in regards to neutralizing antibody activity. It's close to that threshold. It's about 5. Here it's 5.3. If you went to 15 milligram per kilogram, we now have 1,000-fold. You have 3 to the log 10 reduction. And the neutralizing antibody titer is about 7. Remember what the mean neutralizing antibody titer was of healthy adults, about 9. And so here with a titer of about 7 in the cotton rat, we're significantly reducing virus replication. Now, this is what I want to show you, what it means to change from one log to another. Most people, when you say you just have one log increase in neutralizing antibodies, in the vaccine world, they will laugh at you. Say, that means nothing. You haven't done much. You want to see at least a fourfold increase, at least. Well, look at this. The trough level for infants, preterm infants, who are given palivizumab at 15 milligrams per kilogram ranges from 30 to 80 micrograms per ml. That trough level is associated with about 50 to 80% reduction in hospitalization depending on which cohort you're looking at. If you translate 40 micrograms per ml, it has about 6 to the log 2 neutralizing activity. That's the threshold antibody titer that we saw in humans. That's the palivizumab concentration that's associated with at least 50% protection against hospitalization. Let's go back down to 2.5 micrograms and then jump to 5. That's a 1 log increase. You're going from 1.4 to 2.5, 1 log increase in neutralizing activity. Very little amount of palivizumab. Now go again, 5 to 10. Again, a 1 log increase. But note that once you get to about the threshold level, to increase it by 1 log, you have to double it. So you're at 40, you need 80 micrograms to increase neutralizing activity by 1 log. It's exponential increase. You're at 60, to increase it 1 log to 1, you need now 60 more micrograms of palivizumab. You need twice the concentration to increase it by 1 log. And we're talking about neutralizing antibody levels that are below the average adult level. So an average adult truly has a lot of neutralizing antibodies on board to control infection, severe infection, most of the time. So then the obvious question is, why do they get infected? If they have so much antibodies, why do we have breakthrough infections? And so that is a very good question, and there are certain obvious reasons why that may happen. Forget about the host. Forget about the host's ability to respond to the infection. One of the issues that may come up is the viral load. Are you able to, with the same amount of neutralizing antibodies, are you as likely to protect yourself if you have a huge viral load versus a low viral or moderate viral load? And it is very difficult to determine what is the viral load that's causing the infection. But what we do know is infants, when they're infected with RSV, they shed about 1 million plaque-forming units per ml of infectious virus. An adult sheds about 1,000 to 5,000 at most. So there might be a difference there. Another may be the virus. Some viruses may be better fit to infect compared to others. So what did we do? We tried to address that question in vitro. I'll bypass this. We tried to address this issue in vitro to look at the use of what we call prototypical viruses. The prototypical viruses are what we use in our assays, what are often are used to develop vaccines or reagents. And we also use contemporary viruses, those that are currently circulating. We looked at the first, a prototypical virus, RSV Tracy. This belongs to a GA1 genotype. This virus does not circulate anymore. We rarely ever see a GA1 genotype virus in circulation. But it is the prototypical virus that is used in microneutralization assays and oftentimes what is used for vaccine development. So we challenge different concentrations of palivizumab with low inoculum, 1,000 plaque-forming units, and tenfold sequentially higher inoculums. So it went from 1,000 to up to 1 million. And we use 2 doses of palivizumab. A low dose, one that we would see in infants who are prophylaxed with palivizumab of about 40 micrograms per ml, and one that we would see in vaccinated subjects who are given an RSV vaccine of about 320 micrograms per ml. And obviously we have our negative control, no palivizumab. And one can see very quickly that at low doses, if you have more neutralizing antibodies, you are able to, or more palivizumab in this case, you're able to provide protection against, against the virus challenge. But as you go to higher doses, the system gets overwhelmed. And so a question that we do not have is, even though the system may get overwhelmed, are you being protected against severe disease or against infection? And we don't know. So this is all in tissue. We look at the Ontario virus, which was isolated from a patient in MD Anderson, infected with RSV, and look at this virus. This virus at significant viral inoculum, over 100,000 units, or infectious, the higher palivizumab concentration was able to provide protection, sterilizing protection. And it was not until you really had a truly huge dose that it overwhelmed the system. However, the lower palivizumab concentration, you could see breakthrough infections relatively early. Somebody is persistent. Actually, this is my son. He's persistent. I'll get him later. This is RSV B18537. This is a name, but it's a prototypical virus. We don't see this type of virus circulating anymore. We don't see this genotype circulating. And this virus happens to have low-level resistance to palivizumab. So even at the lowest level, you can see some breakthrough infections with 320 micrograms per ml of palivizumab. So there are differences in virus, and this is a virus from Texas Children's Hospital. It's Buenos Aires. It's a contemporary virus, and this virus is sensitive. It's sensitive to either 40 or 320 micrograms. So my point is that it is a hit or miss at times. The only way to improve your odds is to have more neutralizing antibodies. It will not make it 100% effective, but it will improve your odds of not developing severe RSV-related disease. And so I would like to conclude here and end with the issue of the MD Anderson population with RSV, but it can apply to other paramyxoviruses, whether it be parainfluenza 3, whether it be human metapneumovirus, and that is, these viruses are infecting your population. And we don't know whether this population is a subgroup of individuals who just happen to have low baseline antibodies that makes them susceptible to infection with these pathogens, or is it because of the type of therapy they're receiving, you're ablating the B and T cell responses, and thereby really ablating the ability to make new antibodies, and thereby they act more like infants. They have decaying antibodies on board that will make them susceptible until they have an immune reconstitution. So I'd like to end there. Thank you very much.